हेलो एवरीवन, आई वेलकम यू ऑल टू माय चैनल नर्सिंग 360। लास्ट क्लास हम लोगों ने पढ़ाई किया था अबाउट द सेरिब्रोवास्कुलर एक्सीडेंट्स इन वाइट बोर्ड, राइट। सो हम लोगों ने डिस्कस किया था अबाउट द डेफिनेशंस, द कॉजेस, द टाइप्स एंड द प्रोसेस ऑफ द CVA in details, right? So today the second part we will discuss. Let's start with the first pathophysiology of the CVA. So when we have studied the CVA topic, we have discussed there were so many etiological factors or the causative factors. In that, some of the causative factors like obesity, drinking of alcohol, drinking of excessive amount of salty food or spicy food, through which there is a chances of blood pressures increasing, or else there is a chances of clot or plaque formations in the various part of the arteries, right? So when there is a clot formations or thrombus formations in the artery, especially the carotid arteries, when the clot is reaching to the brain, what it will do? It will obstruct the blood flow, right? Or if the blood pressure is raising too high, what will happen? There will be a rupture of the blood vessels inside the brain due to the overpressures, right? And when there is a clot or thrombus formations, that will restrict the blood flow. And when there is a blood vessels rupture, what it will do? It will be leading to the hemorrhage inside the brain parenchymal tissue or the ventricular space, right? जैसे हम लोगों ने पढ़ाई किया था लास्ट क्लास में। फिर क्या होता है? What it will do, right? That blood it will get later it will get clot. So when these two causes, ultimately anyone can happen, okay? So anyone can lead to the ultimately cerebral hypotension, right? Because of the blood flow will restrict. One, what will happen? There will be a clot formations. Another, the blood vessels get rupture. So both the blood will come out, another blood supply will be less. So any of the causes will lead to the cerebral hypotension, and that cerebral hypotension's prolong will lead to the impaired oxygen supply to the brain, right? And when the impaired oxygen supply of the brain will be prolonging long, it will take time, it will lead to the tissue death of the brain. And when the tissue is getting permanently death, any part of the brain it can happen. What it will do? Ultimately it will lead to the CVA clinical presentations. It means the signs and symptoms of a CVA will occur, right? If the CVA is happening through this process, clot process, it will lead to the ischemic stroke. And if there is a blood vessels rupture and that is leading to the cerebrovascular accident, that will lead to the hemorrhagic stroke. So these are the two pathophysiology that we have studied combined, okay? So you can take a snap and just note it for your exam. Now let's talk about the clinical manifestations of the stroke. When we have studied the blood circulations of the brain, there we have discussed that how the blood is supplying to the various part of the brain through the various internal carotid arteries and the vertebral arteries in the first part, right? So the ischemic attack due to any clot or any plaque formations, it can occur any part of the brain, any part of the artery it can get affected, right? And also the hemorrhage can occur any part of the brain. It can occur anterior part, it can occur middle part of the brain, it can occur internal carotid arteries, and also the posterior part of the brain can get affected either through the ischemic attack, either through the hemorrhagic attack. So what happen if the patient is suffering from anterior cerebral artery syndrome? It means the brain anterior part got affected, hemorrhage. What will be the signs and symptoms? That will be contralateral sensory loss. Why it is called contralateral? Now look at this picture very carefully. Now this is the brain, you imagine. Now this is the anterior part, right? So it is the right, let's make it, it is the right and it is the left. So what happen if the patient is having anterior clot at the right side? The patient's left side of the body part will be hemiparesis. If the patient is having left-sided clot formations, so there will be a right-sided body part sensory loss, okay? That contralateral, I mean the opposite cross sensory loss will be occur in the cases of the anterior cerebral artery syndrome. Along with there will be a akinesia. As we know that anterior part is mainly controlling the motor movement of the hands and legs and everything, right? So due to that, if there is a clot formations, there will be neural deficits, and that will lead to the akinesia for the patients. If the middle cerebral artery syndrome or the midbrain is getting affected, what will happen? There will be a ipsilateral gaze deviations of the eye. Now look at this image again. This is the brain. Just a functional understanding purpose I am doing this, okay? What will happen if the clot is forming middle part of the brain, right? What can happen if the patient is having, example, mid portions but right sided clot formations? The patient's eye movement will be towards that clot. Where the clot is forming, that side the patient's vision will be affecting. Their eye movement will be fixed at that side, okay? That's called ipsilateral gaze deviations of the eye, okay? There will be a contralateral facial palsy, okay? Opposite facial palsy will be occur. If the eye movement is right side, the facial palsy will be left side. Because the clot is getting right side formation, so the eye is movement is towards the right side, but the facial, palsy will be there at the left side. And if the clot is at left side of the mid portions of the brain, so the patient's vision will be moved towards the left side. It means the eye will move towards the left side, but the right sided facial palsy will be there, opposite will be there, okay? And then if the mid-brain clot or mid-brain hemorrhage is radiating to the posterior part of the brain, what will happen? There will be a contralateral homonymous hemianopsia. The patients will have a look towards the clot, but the patient can't see the opposite side. There will be a complete blockage of the vision at the opposite side. If there is a internal carotid artery syndrome, it means the internal carotid artery is blocked or stenosis more than 70%. It will shown as a symptoms, right? So that syndromes can lead to both way, okay? This combined syndromes will be there in the cases of more than 70 to 80% stenosis of the internal carotid artery. And if the brain posterior part, it means the posterior cerebral artery is getting damaged or anything hemorrhage occur, we know that posterior part there is a major functions, that is vision. So the persons will have a loss of central vision, there will be a mild hemiplegia, there will be a photophobia, along with there will be a homonymous vision. It means one-sided complete vision will be lost, okay? So these are the signs and symptoms of the stroke. Now let's move on to the diagnostic evolutions of the stroke. Now let's move on to the diagnostic evolutions of the stroke. So there are lots of diagnostic evolutions of the stroke through which we can identify the stroke types. So the first thing will be history collections, a thorough history collections along with ABCD2 score that we have already discussed in the first class, right? So that thing we have to cross check. Second thing, a proper physical examinations, especially the neurological examinations, right? Then MRI, then CT scan. When we will do the CT scan, if the CT scan in the cases of hemorrhagic stroke, if there is a, what will happen? The CT guidelines will show a whitish color in the brain, that indicating that it is getting the hemorrhage inside the brain. And if the CT scan is showing a blackish or the gray color formations inside the CT image, that is indicating the patient is having ischemic stroke, okay? So that through the CT scan we can easily identify this thing. Then blood test, everything like lipid level, all the new all the microelements level check, everything, and then complete CBC, clotting time, bleeding time, everything we have to cross check through the blood test, right? Then cerebral angiography to find out that which side of the artery or which portions of the artery that is getting damaged and that is getting hemorrhage or that is getting ischemic, right? Then carotid ultrasound, through which we can easily find out the plaque or the atherosclerosis in the carotid artery, right? Because if the carotid artery is getting blocked through the carotid ultrasound, we can easily identify. Then ECG. Why we require ECG? Because we know that atrial fibrillations is one of the causes through which the plaque will transfer to the heart, right? And that if the plaque is moving to the brain or the lungs, it can causes either CVA, and if it is moving to the lungs, it can cause pulmonary embolism, right? So atrial fibrillations is one of the conditions through which the patient is getting CVA. So to find out that, we need a ECG. Okay, so these are the most important diagnostic evaluations of the CVA. Now let's move on to the most important part, that is the treatment of the CVA. So when we will study the management, we will divide the management into two types. First of all, there will be a separate management of the ischemic stroke, and also there will be a management of hemorrhagic stroke. So we know the main reason of ischemic stroke, that is either any clot or any plaque that will travel inside the brain where the blood flow will be restricted, right? So what happened after diagnostic evaluations, when the doctor will find out that there is a ischemia is happening inside the brain, and due to that reason the patient is having focal neural deficits or some clinical symptoms of the stroke, what the doctor will do? The doctor will provide the first TPA, okay, that is tissue plasminogen activators. What the tissue plasminogen activators it will do? It will help to relieve the clot, right? And but also you have to make sure that you have diagnosed within 4 to 5 hours of the patient's complaint. Okay, if within that period you may have find out and you have administered the TPA, so the chances of the clot can get break. But if there is any contraindications, example, the patient is having something prior or previous brain injury, or else the patients may have excessive diabetic conditions. If you are providing the TPA, what will be the deadliest thing? The TPA can lead to hemorrhagic stroke. It means the ischemic stroke, it can convert into hemorrhagic stroke, because TPA, when it will break the clot, what it will do? It will also rupture the blood vessels. So there was no bleeding at the first point. But what happened? When you provided the TPA with some contraindications conditions, that will lead to the blood vessels damage, and there will be a bleeding inside the brain, and that finally will lead to the hemorrhagic stroke. So here what you are doing, you are making the complications for the patient. So make sure there is no complications or no contraindications, and you are administering the TPA, right? So after TPA, after 24 hours, what we will do, or immediately we can take, that is ECG. Why we will take the ECG? To diagnose the atrial fibrillations that we have discussed, right? So if we find out that there is the atrial fibrillations conditions of the patients, what we will provide? We will provide the anticoagulant agent. So the best choice will be warfarin, okay? Then echo we will do. When we will do the echo, if you find there is a clot, what we will provide? The same, either anticoagulant or antiplatelet agents, right? And when we will perform the carotid ultrasound, if we find out the carotid artery stenosis by plaque formations more than 70%, we have to perform carotid stent or carotid stenting. And if there is a less than 70% clot or stenosis, we can treat the conditions through medical management only, okay? And then here you have to remember one thing, that ischemic stroke, it's mainly occurring because lack of blood supply, okay? So what you have to do, you have to maintain, and sometimes you may have to increase the BP, that is called permissive blood pressure should be elevated, okay, और शुड बी स्टेबलाइज. बिकॉज अगर आपने पेशेंट्स का ब्लड प्रेशर को रिड्यूस कर दिया तो क्या होगा, ब्लड जो ब्रेन तक पहुंच रहा था वो और भी रेस्ट्रिक्ट हो जाएगा, है ना. फिर वो इस्केमिक जो अटैक था वो और भी इंक्रीज हो जाएगा, एंड पेशेंट का जो कंडीशंस है, जो टिश्यू डेथ का जो रेट है वो इंक्रीज हो जाएगा, है ना। सो हम क्या करेंगे यहाँ पे बीपी को हम लोग इमीडिएटली रिड्यूस नहीं करेंगे, उसको हम लोग सस्टेन रखेंगे, या फिर अगर ज़रूरत है तो उसको हम लोग थोड़ा इंक्रीज करेंगे। ओके, सो अगर पेशेंट्स को हम लोग टीपीए प्रोवाइड कर रहे हैं, अगर प्लाज्मिनोजन एक्टिवेटर अगर प्रोवाइड कर रहे हैं, तो बीपी कितना होना चाहिए, तो सिस्टोलिक है वो लेस देन 180 and diastolic should be 105. But if the patient is contraindicated where we are not providing the TPA, we have to maintain the BP above or about to be systolic should be 220 and the diastolic should be 110, because the blood pressure, if it is maintaining, it will reach to the brain various part, right? If the blood is not reaching to the brain properly, what will happen? The necrosis, the tissue death will occur more and more. So there is a high damage of the brain will occur. That is why in the first period we will not reduce the BP. But once the clot will move away, we can control the BP with some medications. Okay. Then some insulin drip also we can provide to treat the normal glycemia conditions. Then DVD prophylaxis. Okay. And when the deep vein thrombosis prophylaxis, we have to provide the DVD stockings, then DVD some medications, okay. Then oxygen therapy, supportive therapy, then cardiac arrhythmic also we have to treat to the patients, okay. There should be some treatment for the cardiac arrhythmias, okay. So these are the basic management of, and also the important management of the ischemic stroke. Take a snap. Done. Let's move on to the hemorrhagic stroke management. So now let's talk about the hemorrhagic stroke management. When a patients come to the hospital with the chief complaints of slurred speech or any focal neural deficits along with some headache, which may represent the clinical symptoms of stroke, when the patients will come, our first duty will be to maintain the neuro safety, okay, or neuroprotective measurement is the first prime point. Okay, so that is called the golden hour concept. In golden hour concept, the first hour of management of that particular ischemic conditions which will protect the patient in first hour, that is most important thing. The first, what we will do, we will check the ABC survey. It means airway, breathing and circulation process. In that, especially we will check the circulations process. Okay, then go for the neurological assessment, right? And then when we will find out the patient SpO2 level, everything, blood glucose level, everything we will check in the emergency ward. So when we will find out the oxygen level is decreased, as a supportive management we can provide the oxygen either through the mask or through the nasal cannula. When there is a severe oxygen shortage, what we will do, we will intubate the patients, right? Then maintain the normocapnia. What is normocapnia? It's the maintenance of the oxygen and the carbon dioxide level, as excessive amount of, if carbon dioxide is increasing in the blood, that may lead to the hemorrhage more. Okay, so in ventilation process, there is a regulations process through which we can maintain the carbon dioxide level in such a way so the vasoconstrictions will take place and there will be a normal blood supply in the blood vessels. So there will be a lack of risk to get more and more bleed. Next thing what we will do, we have to check the blood glucose level of the patients, right? And then we have to maintain the normoglycemic level, because it has been found by so many studies that increased glucose level may lead to the mortality rate of the CVA. Okay, so it's better to maintain the normal glucose level by insulin drip and then maintain normothermia. Okay, because thermoregulations is one of the most vital management to control the bleeding. That is why this is all the golden hour or the first hour management of the hemorrhagic stroke. And as we have studied the ischemic stroke previously, ischemic stroke का जो मेन कारण होता है वो है कोई प्लाक या फिर कोई भी थ्रोम्बस जब वो आर्टरीज के अंदर पहुंच जाता है तो वहां पे ठीक से ब्लड सर्कुलेशन नहीं हो पाता है ना। तो वहां पे अगर हम लोग ब्लड का जो प्रेशर है उसको अगर हम लोग रिड्यूस कर दे तो क्या होता है, ब्लड और भी ठीक से नहीं पहुंच पाता है एंड इस्केमिक जो कंडीशन है वो बहुत ज़्यादा फैटल हो जाता है। लेकिन यहाँ पे हेमरेजिक स्ट्रोक में क्या होता है, हमारा जो आर्टरीज है वो ऑलरेडी डैमेज होना शुरू करता है, तो वहाँ पे जो ब्लड का जो प्रेशर्स है वो प्रेशर्स को हम लोग को यहाँ पे कंट्रोल करना पड़ता है। सो जो प्रेशर्स हम लोग रखेंगे वो अप्रोक्स कितना होना चाहिए, दैट शुड बी अंडर 140 to 180 सिस्टोलिक मेनली होना चाहिए। एंड टू कंट्रोल द ब्लड प्रेशर्स, व्हाट आर द ड्रग्स वी कैन यूज कैल्शियम चैनल ब्लॉकर्स, एग्जांपल नाइकाडिपिन 5 to 15 mg every hourly, okay, or else we can use the labetalol, which is beta blocker 20 mg IV every 10 minutes we can provide to control the BP, because ischemic conditions we have to sustaining the BP or we have to increase the BP, and in these cases of hemorrhagic stroke we have to reduce the BP. So there is a much difference of the both management, right? So don't write blindly that calcium channel blockers, beta blockers, because both of the stroke types is different, so their management process also will be different, okay. Next thing, anticoagulant reversal. हम लोग ischemic stroke में क्या किए थे, we have provided some anticoagulants or antiplatelets, right? Example TPA, tissue plasminogen activators, which will break the clot and which will improve the circulations. But in the cases of hemorrhagic stroke, we have to stop the anticoagulant, because if you are providing the anticoagulant in the cases of hemorrhagic stroke, what will be the problem? It will improve the blood circulations and that will improve the bleeding. So we have to stop the anticoagulant therapy, because आप पेशेंट्स को अगर एंटीकोआगुलेंट प्रोवाइड करते हो इन द केसेस ऑफ हेमोरेजिक स्ट्रोक, व्हाट विल बी द डेंजर फॉर द पेशेंट्स? एंटीकोआगुलेंट क्या करेगा, उस ब्लड का जो सर्कुलेशन है उसको इंक्रीज करेगा, है ना। और ब्लड सर्कुलेशन अगर इंक्रीज हो जाए तो वहां पे जो ब्लीडिंग जिसको हम लोग कंट्रोल करने की कोशिश कर रहे हैं तो वो कंट्रोल नहीं होगा, वो उल्टा इंक्रीज हो जाएगा। फिर कंडीशंस क्या होगा, वो और भी ज्यादा फैटल हो जाएगा। तो यहाँ पे हम लोग एंटी जो कोआगुलेंट है, जो थेरेपी अगर हम लोग प्रोवाइड कर रहे थे तो उसको हम लोग इमीडिएटली स्टॉप करेंगे, राइट। एंड देन कंटिन्यूअस ब्लीडिंग एंड क्लॉट फॉर्मेशंस के वजह से क्या होगा, पेशेंट्स आईसीपी विल बी इंक्रीज मोर देन नॉर्मल, आईसीपी हो जाएगा। एंड आईसीपी अगर ज्यादा इंक्रीज होता है तो क्या होगा, पेशेंट्स को कुशिन रिफ्लेक्स होता है ना। कुशिन रिफ्लेक्स में क्या क्या रहता है, ब्राडिकार्डिया होता है, बीपी जो है वो बहुत हाई रेंज पे पहुंच जाता है, पेशेंट्स विल हैव अ चेन स्ट्रोक्स ब्रीदिंग, देन पेशेंट्स हेडेक विल बी देयर, वेरी सीवियर हेडेक विल बी देयर। सो दोज ऑल सिंड्रोम और द क्लासिफिकेशंस वी विल नो एज कुशिन रिफ्लेक्स। सो कुशिन रिफ्लेक्स को कंट्रोल करने के लिए हम लोग को क्या करना पड़ेगा, इट मीन्स आईसीपी मेनली कंट्रोल मैनेजमेंट के लिए हम लोग को पेशेंट्स को जो हेड है उसको हम लोग 30 डिग्री एलिवेशन करके रखेंगे। मतलब पेशेंट्स का जो बेड है जहाँ पे पेशेंट्स को रेस्ट में हम लोग करेंगे तो वहाँ पे पेशेंट्स का जो हेड है वो 30 डिग्री तक एलिवेट होना चाहिए। फिर क्या होगा, जो फ्लूइड या फिर जो ब्लड वहाँ पे एक्यूमुलेट हो रहा था वो बाय द ग्रेविटेशन फोर्स वो नीचे की तरफ आना शुरू होगा, है ना। देन हम लोग हाइपर ऑस्मोलर थेरेपी हम लोग यूज करेंगे, आइदर वी कैन यूज द हाइपरटोनिक सलाइन, आइदर यू कैन यूज द मैनिटोल, ओके। सो दे बोथ आर ऑस्मोटिक एजेंट्स। व्हाट इट विल डू, इट विल extract the overload of the fluid from the body, from the brain cavity, so there will be a reduction and the ICP will be maintained, okay. And then if both things are failed to maintain, we can use the VP shunt. Usually क्या होता है कि hyperosmolar therapy and mannitol के यूज करने के वजह से पेशेंट का जो ICP है वो नॉर्मल तक पहुंच जाता है। Also we have to provide the anti-epileptic drug, but when we will provide, when the patients will develop epilepsy. Priorly we should not provide the anti-epileptic drug as a prophylaxis, because यहाँ पे अगर पेशेंट्स को एपिलेप्सी आता है तभी भी आप प्रोवाइड कर सकते हो, अदरवाइज प्रायरली आपको अगर लग रहा है कि नहीं पेशेंट्स इन द फ्यूचर द पेशेंट्स में डेवलप द एपिलेप्सी, ये सोच के आप कभी भी उसको एंटी एपिलेप्टिक ड्रग प्रोवाइड ना करें। इट्स अ स्टैंडर्ड मैनेजमेंट है जो हम लोग यूजुअली गलती कर बैठते हैं, ठीक है। सो देन सर्जिकल मैनेजमेंट, अगर क्लॉट बहुत देर तक ब्रेन कैविटीज के अंदर अगर फॉर्मेशन हो जाता है तो उसको एक्सट्रैक्ट करना बहुत मुश्किल होता है इन सब प्रोसेस के थ्रू। तो हम क्या करेंगे, हम आइदर हेमाटोमा एवैक्यूएशंस करेंगे, जहां पे एक स्मॉल ओपनिंग के वजह से यूजुअली जो क्लॉट होता है उसको हम लोग रिमूव करेंगे, लेकिन वो क्लॉट अबव और मोर देन 3 सेंटीमीटर होना चाहिए, तभी जाके हम लोग ये प्रोसीजर परफॉर्म कर सकते हैं। और एल्स वी कैन परफॉर्म द डीकॉम्प्रेसिव क्रेनियोटॉमी। तो यहाँ पे क्या होता है, इसका जो मेन एम है कि ब्रेन हर्निएशंस को प्रिवेंट करना। व्हाट इज ब्रेन हर्निएशंस? एग्जांपल, ये आपका ब्रेन है और ये आपका ब्रेन टिश्यू है। सो कोई भी पार्ट में अगर ब्लीडिंग अगर ऑकर होता है तो क्या करते हो, वो क्लॉट उस ब्रेन टिश्यू और हेमिस्फेयर को, एंटायर हेमिस्फेयर को और उस पार्ट को मिड लाइन से वो शिफ्ट करता है कोई भी लैटरल पोजीशंस के तरफ, और जो पेशेंट्स का डेथ का मेन कारण होता है ब्रेन हर्निएशंस। सो उसको प्रिवेंट करने के लिए हम क्या करेंगे, वो जो पर्टिकुलर जो पार्ट जहां पे क्लॉट फॉर्मेशन हुआ है उसको हम लोग कट करके रिमूव कर लेंगे। एंड वो जब हम लोग रिमूव कर लेंगे फिर क्या होगा, जो प्रेशर्स एक्स्ट्रा जनरेट हो रहा था ब्रेन कैविटीज के अंदर वो अल्टीमेटली बंद हो जाएगा, एंड ब्रेन का जो पोजीशंस है मिड लाइन पे वो ब्रेन का पोजीशंस को मेंटेन रखेगा। सो टू मेंटेन द मिड लाइन पोजीशंस ऑफ द ब्रेन वी हैव टू परफॉर्म द decompressive craniotomy. Okay, then as a supportive management we have to provide NG feeding because the patients can't take the food from orally, then some passive exercise, physiotherapy, daily basis care, example daily care, right? And then catheterizations must, because the patients won't be able to pass the urine, so catheterizations and daily catheter care to prevent the infections from the other sources. So these are the exact management of stroke that we should perform on a patients. I know this topic is quite big for you, but this topic itself is very critical. Every person's their own way of individual stroke is very, very difficult to management. So we should always study the standardized management. Okay, so don't give your knowledge in a compromised way. Always try to learn broad and more way. Okay, so if you like such informative classes, don't forget to like the videos, share the videos and hit the subscribe button so you will not miss any update from the channel. Thank you all.